Welcome back. And in this session, we will see something related with the long COVID condition and how we can use the primary and secondary purposes of the EHDS to do something about long COVID condition. My name is Stefano Dalmiani from Monastero Foundation, that is a public research hospital, one of the pilot sites of xShare project. So let's start with a different point of view, different perspectives, with the brief patient story where Natalie contracted COVID, of course, and then never fully recovered from that infection. She experienced fatigue, muscle pain, brain fog, and increased stress sensitivity. They, of course, were visited by GPs and specialists, but with no conclusion. And so she was diagnosed with long COVID. And she alternates between working and taking sick leave. So this is a really common condition for long COVID patients. She understood also because she was aware of the potentiality of the information that her care processes was generating that could help research. And this is mostly common in patients associations and networks that is really eager also to send the data that can help in understanding at least the condition. This is Natalie with a long list of condition problems, but we might see that she is a well-organized patient, and she has a fair amount of digital literacy. This is crucial for the usage of electronic tools. And we have the GP's point of view. So Dr. Lambert encountered some patient with persistent and diverse symptoms, and after, of course, the COVID infection, and found it challenging to identify long COVID and to provide adequate support. And this is, of course, something common with the basic COVID condition. So with the certain, let me say, proactive intelligence, adapted his approach, including the recognition of the patient reported experiences coming from the patient directly. So the prompts and prompts aspects. He was also aware of the implementation of the HRXF. The xShare project is all about an early adoption, an early experimental usage of the HRXF that is based basically on HS7 Fire. And he sees a positive shift with the implementation and with the adoption. Of course, we are talking about the HR system and the line of the healthcare processes. And he can share also information with the patient. Both patient and general practitioner feel part of a shared ecosystem. This is all about the EHDS, the creation of a shared ecosystem. Of course, when Dr. Lambert sees another patient, relevant patient for the long COVID project or experimental research, supports, ask the patient the completion of prompts or PREMS questionnaire, basically, through the yellow button that is a specific technological point in the xShare that enable the patient to do something in their own control of information, in their own control of information flows, of course. This is Dr. Lambert, and we see that he is also well-organized physician. We don't have this the assessment for digital literacy, but we might understand that he is really understanding that he is aware of the HRXF, is very keen in using technologies. And this is the final point of view. Jean, She's a medical researcher. She is focused on the long COVID study. So she, of course, encounters all the different aspects of long COVID care, starting from the uncertainty of defining what long COVID is exactly out of the symptoms. So the root causes of long COVID, of course, is COVID, but we don't know much more. So far, nothing established. Several studies are going on right now, and several studies are producing consistent advancements in the study of COVID. So in xShare, the long COVID scenario is explained as the capacity to identify patients who have possibly been affected by long COVID. So we are talking about a wide range, wide spectrum of people. This patient, after faced with conflicting diagnosis, elect opioid follow-up, just like we mentioned in the previous description. So the xShare scenario enables the patient to be oriented towards adopt a dedicated structure, just like the xShare button. And the yellow button should enable citizens to become active contributors to knowledge update and research. We will explore this in this brief schema, starting from an initial communication campaign and starting actually from the definition of research study that is focused on COVID. The research study needs to enroll patients. So the communication campaign is just to tell each patient, okay, you might be diagnosed because of your symptoms for a long COVID study. So I identify myself, or my GP or my specialist identify my diagnosis, but the patient holds the data in xShare. So the patient asks to download the information. The patient uploads information in a research platform. This is proactive. This is the direct involvement of a patient in his or her own care. And then the research study notifies this enrollment, this self-enrollment actually, to the clinician, and the clinician can validate the care plan according also to the information that were collected and sent to the clinician. And the patient can provide new information also. And this is translational research. So we define the theoretical approach, we test it, and we go back to the theoretical approach. And this is supported by the xShare yellow button. We will see today a list of panelists that can help us to understand the different point of views and what are the perspective of the single point of view. So I invite here Carmen. Carmen van Looy from Not Recovered, Belgium. Carmen will share her patient experience in a country which has already measured data sharing architecture. So she will share us all the efforts she had to make as a key health data provider to make her data available. Please, Carmen.
Good morning. My name is Carmen van Looy. I am a single mother of a daughter of 10. I graduated as a commercial engineer and I work as a project manager for the Flemish government. I haven't been able to work since the beginning of 2021 when I contracted COVID. I co-founded the patient group Not Recovered Belgium, and this year I'm also following a course to become a patient expert, to be able to speak out even more about the needs of patients. So thank you. My journey with COVID started on March 18, 2021. Then I had a positive PCR test and I was briefly hospitalized. After the acute phase, I got better, but right after, all different kinds of symptoms appeared. What followed was a long and difficult trajectory. Rehabilitation in hospital. They put me with 3 persons on a stationary bike, but still then I was unable to spin the wheels. In a couple of weeks, my muscles became stronger, but all my other symptoms became a lot worse. By the end of 2021, I was most of the time bedridden and needed a reclining wheelchair because I fainted of low blood pressure by simply lifting my head. I was sent from doctor to specialist who advised nothing more than movement and psychological sessions. After long years on waiting lists, in 2025, I finally saw some specialists, all based in Wallonie, who are familiar with post-acute infectious diseases. They started different medical treatments on the different systems in my body that didn't function properly. And then something shifted almost overnight. This year, my body systems are rebooting. I can walk, I can ride my bike, I can function for several hours a day, but only with strict pacing and careful medication. Reinfections still have a really huge impact on me. I have now been ill for 1,833 days. I was followed by a journalist, and she made a summary of all my medical documents. So in there, she noticed that I experienced 78 different symptoms. For long COVID, there are more than 200 known long COVID symptoms. I have a debilitating fatigue, post-exertional malaise, cognitive issues, cardiovascular problems, pain, inflammation, hormonal and neurological issues. I've had 75 doctor's appointments in 12 hospitals and with 18 specialists, more than 100 tests, and I followed dozens of therapies. Each specialist looked at one or two symptoms, even though this is clearly a multi-system disease. The first years, I received no treatment at all. For example, fixing my orthostatic low blood pressure with a therapist, it didn't work, of course. Instead, treating the inside of my damaged blood vessels based on worldwide long COVID research worked like magic in a few weeks after a few years. I can't explain how much more quality of life you can have when you can sit or stand without fainting. In the Netherlands, these orthostatic dysfunction tests and treatments are standard in the long COVID centers and in educational sessions for doctors. One of the biggest challenges is this. As a patient, I am connecting the dots. I repeat my story over and over again to doctors, specialists, and researchers. My data is spread across systems, often incomplete and difficult to access. There's no single shared overview. The result, delays in diagnoses and care for patients, and a burden on the patient. Long COVID affects 36 million Europeans. That's 1 in 30. We have to consider the impact of the economy when these patients remain untreated. Long COVID is complex. It overlaps with other conditions, but it's not new. Post-acute infectious diseases exist for decades, but they didn't receive enough funding in the past. As a result, many patients are still undiagnosed, misdiagnosed, or their symptoms are psychologized too quickly. There are many studies on long COVID worldwide. A cure will be found. I truly believe it. But as a patient in Belgium, we experience difficulties. Long COVID is not recognized as a chronic or serious disease. There are no investments in biomedical research, and we don't have experience centers as there are in our surrounding countries. There's no patient database as there is, for example, in the Netherlands. And when there are studies, it is difficult to find them and even harder for them to find us. Another issue is that important data is missing. For example, daily symptoms, energy levels, crashes, data from wearables. This is essential to truly understand long COVID. So what would make a difference? First, a shared and complete patient view. One health record accessible to all relevant professionals. Smarter use of data to help identify possible long COVID cases earlier. We also want to be actively included in research. If I match a study, I want to be invited. We also want control over our data, so we can decide when and how to share it. Finally, I want my real-life experience to count. Patient-reported outcomes, daily functioning, quality of life, these should be part of the data. And if my data is used, I would like to receive something back. Insights, feedback, knowledge. To summarize, I'm not just a patient, I'm also a source of knowledge. Today, my data is fragmented, but I know it could help to understand long COVID, improve care and support research. I thank you.
Thank you, Carmen, for this vivid picture. We resonate with your problem. And this confirms also that long COVID can be depicted with the lack of information of a rare disease, but we know it's not a rare disease. So we need to know something more. We need to stress perhaps the not only data collection, but the scientific community on studying this. The next speaker is Robert Vander Stichele, that is a GP from the University again and IHD, sorry. And Robert will present the innovative approach followed by a cohort of Belgian GPs led by Dr. Marc Jamuil, which published Long COVID Invisible Disease. The report documents its appropriate conduction and findings with the direct involvement of a cohort of 300 patients. Please help me welcoming Robert.
Good morning, everybody. So we'll tell you a story about bottom-up data collection by one general practitioner who, after the COVID epidemic, specialized in the patients that he discovered to be long COVID patients and started a cohort of these patients. It's one general practitioner. He used one medical record, MediSpring, consistently coding in one system, and then following a research protocol for data collection, communication with the patient, and communication with the referring physicians. This cohort integrates data from his own medical record keeping, which was coded in ICPC, International Classification of Primary Care, data from the eHealth Belgium data hubs, which allow, if you use the metadata of them, to construct the pathway, the trajectory of patients over years, and illustrating the sometimes chaotic pathways of these patients. Integrating structured patient-filled questionnaires, severity and function status codes, the narratives of patients, the invitation to tell their own story, write it down and integrate it in the records, and systematic assessment of symptoms and codifications in human phenotype ontology. This is all clinical work done by the GP, and then there were a number of blood samples sent to the KUL for advanced research, proteomics and transcriptomics. But from the clinical side, I think this was a collection of gold standard clinical data for more than 400 patients since July 2001. The objective of this collection is to focus on humanistic, holistic partnership for patient care, to collect the patient experience, to explore the trajectories and the natural disease, standardize the record keeping, compare phenotypes with multi-omics biological data, and assure ethical safeguard. There's a contract between the patient and the doctor. There's a committee, the University of Liège ethical approval. Patients participating in research and giving blood samples were fully informed, and the data are pseudonymized for sharing with the researchers, with the key kept in the practice. I'm going to quickly go over some results of this thing, and then focus on the sharing, further sharing of these data in European context. This is the geographical distribution. The doctor lives in Charleroi. You see Brussels, you see Charleroi. The red points are the patients of the doctor himself, and the blue ones from other colleagues. Sex distribution, age distribution, and very importantly here, severity indexes seen by the doctor and seen by the patient. This is the date of the original COVID infection for the acute infection for the patients, the distribution of it. These are the symptoms. And you see a lot of neurological problems, fatigue, memory impairment, headache, cognitive impairment, brain fog, predominantly, and the distribution over the patients of these symptoms coded from the textual analysis with a large language model and brought to human phenotype ontology. Sorry. Around this cohort, a network has been created of specialists and people, advanced research people who are interested in these data. More than 300 blood samples biopsies were sent to the Rega Institute, and for imagery, mostly SPECT CT was done. And it's also an anthropological analysis of these patients. From this grassroots collection of data is already a quite impressive publication without the need to share it on the European level, but just using internally the data has been, and others are to follow. And in this cohort, the keepers of this cohort have the research hypothesis that long COVID is a chronic viral disease, severely disabling, fluctuating, neurotropic, and multisystemic, and that the sustained symptoms are caused by persistent fibrosis. In public health terms, its impact is as significant as multiple sclerosis. Now, this comes to, for this audience, the most important, the perspectives on data sharing for secondary use. What we did with all these 400 patients in one electronic health record, we have in Belgium something that is called the patient migration format. It's an export of a loose container of the structured and unstructured data in an electronic record, and it's used to allow patients to change from one GP to another when they move. We used that output of the electronic record to construct, with a program to construct an IPS, an electronic patient summary. No artificial intelligence, just picking data from one system and putting it in another system. That has already been established. The program works to transform these data into an IPS, and it could be used for secondary use. But we decided now that putting the data in IPS means loss of context. That you have in an electronic record, there is architecture, there's templates, there are archetypes. A telematic message like the IPS is a flat file, and you lose a lot of context. So we're now building a system where we move the data from the different records to an OpenHR standardized generic electronic record system. And from there, we have already all the functionalities to produce FHIR resources like IPS or to transfer the data in OMOP. But there are for us some requirements for sharing these data for secondary use with the EU initiatives like xShare and IHE-DS and Odyssey. The safeguards for privacy and ethical conduct need to be in place. We also would like have this voluntary effort to have some guarantees for continuity and further standardization of the primary data with terminology, SNOMED, but also under other terminologies and multi-terminology. It's important for these things. For instance, for symptoms of long COVID, if you really read it very precise, you will need the human phenotype ontology. SNOMED will not be enough. And then it could be expanded to other practices. So thank you. That's what I wanted to say.
Thank you, Robert. Your experience is really valuable, and this is an example on how different research protocols can be supported by a technological layer, but not only, because we need the clinical expertise and researchers really focus and with experience in the management also on novel diseases just like long COVID. The next speaker is Bianca Boxma-de Klerk from the Netherlands and the Post-COVID Netherlands Network. The network is led by Leiden University Medical Center and is a national partnership bringing together university hospitals, but also patient association, paramedical partners, and public organizations, just like the RIVM. So please, Bianca, the floor is yours.
Well, thank you very much for this opportunity to tell something about the Dutch Post-COVID Network, otherwise known as PCNN. My name is Bianca Boxma-de Klerk, and I'm a clinical epidemiologist and assistant professor at the Department of Clinical Epidemiology at the Leiden University Medical Center in the Netherlands. PCNN was launched on March 1st, 2024, so we're 2 years ongoing, and it was launched as a nationwide network for post-COVID research. And the network is formed by 7 parallel work packages and 4 platforms crossing them as shown on the slide. Our work packages cover real-world data, a nationwide biobank, translational research, a platform trial whose logistical basis can be used at request, that's from Reclaim, pathophysiology work package, and a work package for implementation and development of a practical care path. And crossing these platforms entail methodology and data harmonization, patient representatives, ethics, and knowledge dissemination. My work is here as I'm a program manager for both Work Package 2 and Platform 1, so combining real-world data and methodology, including verification. And I'm also part of the steering group in Work Package 1, and I will tell you how we work regarding the data. Our work package real-world data is divided in 3 sub-packages, metadata dictionary, a patient portal, and a data environment, all of which I will address. So first, we've built a metadata format, which is available through our GitHub, for which the QR code is available at the last slide of this presentation. We collected metadata of 32 Dutch post-COVID studies that were already ongoing or finished at the start of PCNN in 2024. For all new studies starting and that are affiliated with PCNN, we collect the same metadata, and we are working on a searchable online tool to stimulate reuse of this data. This online tool will connect with the Health DCAT, so the Dutch metadata schema under the EHDS. We've built a patient portal hosted at the RIVM, so the Dutch National Institute for Public Health and Environment, and patients with self-reported post-COVID can voluntarily register if they are willing to participate in scientific research. The portal started in June 2024 and has a 3-monthly follow-up, and approximately 16,000 patients registered at baseline and about 5,000 to 8,000 patients are still being followed up. We measure PROMs, patient characteristics and disease characteristics, and all patients gave informed consent to use the data for post-COVID research, and patients can register what type of research they are willing to participate in. Researchers can select and recruit patients through the portal after approval of PCNN, and this speeds up inclusion in studies. You can imagine if you're looking for 100 patients with PAM, you can select them through the portal. Patients can use the dashboard to monitor the development of their own complaints through the PROMs and share this progress with their healthcare professional for monitoring, and of course can be invited to participate in research on their disease based on their own characteristics. The research environment. Well, data that is collected in the patient portal is stored at Statistics Netherlands, the CBS, and merged with CBS microdata such as hospital data, GP data, and reimbursement data. And the intention is that the study portal is available for research at request, since it is important to use the collected data well. So when starting a new research related to the PCNN, researchers ask their included patients if their study data may be reused in future research and merged with portal data and other sources in the CBS environment. For this, we provide a standardized appendix for the patient information form, and the CBS provides a secure data environment where patient data is fully anonymized and researchers can analyze data and output will be checked before releasing it. So even though it was not part of the original plan, we feel it's important to also build a tool to manage and get insight into the study activities in PCNN. This online tool should become the main gateway for contact within with the network, and we will organize processes for this, including standard operating procedures. And this process we ensure to be able to advise and assist researchers regarding methodology, ethics, data harmonization, patient contact, and planning of dissemination, as well as organize the logistics side of things, for example, for data and sample use and other parts of the infrastructure. So next is platform 1. So aside from advising a methodology, we focus on harmonization of data and the central codebook. The codebook is being built in a JSON format to ensure machine readability, and we use common FAIR ontologies such as SNOMED-CT and Looy to harmonize internationally. And we aim to include all variables collected within the PCNN, so both in the new studies, as well as the metadata dictionary, the patient portal, and the study management tool. And regarding harmonization, we intend to limit the burden of filling out questionnaires for patients as much as possible. So data collection in the portal can be paused when participating in a study that also collects data and will be reshared with PCNN in the end, as well as patients undergoing treatment in a post-COVID expertise clinics where they also fill out PROMs. As a service for researchers, we also provide castor forms that are in line with our codebook to help researchers build their study database in Castor EDC. It's electronic data capture software that's frequently used in the Netherlands. And of course, researchers are free to use other software for their data collection, but then they need to build their database themselves following the codebook. So alongside the PCNN, we have 6 post-COVID expertise clinics for adults in the Netherlands and 3 for children. And these are situated in university medical centers, of which we have 7 in total, distributed over the whole country. In these expertise clinics, medical specialists are taking time to see and learn from patients with post-COVID and help them as best they can, and aim to distribute the gained knowledge with the first and second line of care. There is overlap in people who are involved in both PCNN and the expertise clinics, which benefits communication. And data collection between PCNN and the expertise clinics is harmonized for the majority of the collected data, but sometimes slightly different information is needed for clinical practice versus research. And patients who are in the waiting list for the expertise clinics are asked to register at the patient portal to serve as controls for evaluation of development of care in the expertise clinics. And this way, patients can be monitored over a long period of time after the treatment has ended in these expertise clinics. So the development of PCNN is still very much ongoing. And to wrap up this presentation, some points that we still aim to develop is first, we would like to embed the patient portal data collection in regular healthcare practice, kind of similar as the yellow button that is proposed. In due time, we hope to broaden our scope to also other PIs, and we hope to combine more data sources, including data from post-COVID expertise clinics, and to develop the discussed online tools. So this wraps up my presentation. I thank you very much for listening, and please free to ask questions now or later by email, and you can use the QR code to access the GitHub or the email pcnn@lumc.nl if you want to contact us. Thank you very much.
Thank you, Bianca.
I have just a short question, Bianca. Is there an ongoing campaign all the time, so that the people who believe they are possible long COVID patients can connect with the network? How do you organize your communication?
Well, we have post-COVID NL and long COVID, the patient organizations that are quite vocal on LinkedIn and their own newsletters and websites about the possibility to participate in these data collection. And we also have waiting room screens that GPs can use in their own practice to inform patients about the possibility to participate. And we try to inform as many GPs as possible through the national academic networks that patients can join. So we do our best, but I don't think we are already reaching everyone we would like to.
Well, thank you, Bianca. And this is a really good example of when a country wants to move and solve the problem, needs to be organized, needs to start some specific project to address the specific needs of the population. So thank you, Bianca, for exposing us your experience and very well structured network. Thank you again. So Helena Liira is a chief physician from the Helsinki University Hospital in Finland, of course, about the long COVID project. This EU project led by the Helsinki Hospital relies on 6 long COVID cohorts, 4 in Finland, 1 in the Netherlands, and 1 in Switzerland. Its main innovation is related to AI-based biomarker, i.e. digital biomarkers, the discovery of multimodal data. So we are talking about a huge data collection also, or very different data collection, and propose a long COVID data portal to collect the data for LCS research, and is developing novel methods for harmonizing and accessing integrating data. Please, Helena, join us and explain us.
Thank you for the invitation to this seminar. So how we got started? I'm a general practitioner by training, but I work in tertiary care hospital in academic generalist roles. And 5 years ago, our hospital decided to found a long COVID clinic, and I was invited to organize that. The model was from Sweden. We always follow Sweden, and Karolinska had opened a clinic. So we got the clinic up and running in June 21. At the same time, there was an EU Horizon call on post-infectious conditions, and we decided to apply. And because I had a research background, I immediately organized a cohort study following the prompts of these patients. But then for the mechanistic EU proposal, we contacted biomechanistic researchers in Finland and elsewhere, and also clinical partners. This is my co-coordinator, Mari Kanerva, who is a specialist in infectious diseases. So we got the project together, and it has the cohorts as mentioned, but also quite a wide range of mechanistic and pathogenetic studies and translational biomarker studies. We also have a work package for interventional studies. We have studied digital net therapies for long COVID. And in the beginning, we had 2 companies here, quite high-tech companies, NEC Italy and then Neuromedia. And their recommendation was to organize a centralized data management organized by by neuromedia, and then NEC would do the AI analysis, etc. there. We have several countries involved. The patient data comes from Basel, Switzerland. They have a similar post-COVID clinic there as we have in Helsinki. But we also have data from the Dutch Lifelines population cohort. And so the data comes from 3 countries, and it is analyzed in Helsinki, in many labs in Helsinki University, but also in Estonia. There's a proteomics lab there, and then the lipidomics lab was in Germany. So originally Neuromedia, a company from Germany, was supposed to provide the data platform for the project. However, Lifelines clarified early on that their data would remain in the Netherlands due to data protection. And when we got started in 2022, there was a strong recommendation from our IT that the data would need to be stored in HUS Academic, a new safe environment for data, which opened 2022, like a year later than we applied for this proposal. After that, our data management plan was changed so that we now host both the Finnish and Swiss data and all the omics data, etc. in Finland in this HUS Academic, which is a secure, scalable, virtual, audited environment that meets the Finnish Secondary Use Act. And it also complies with the national FinData's regulations. It can be operated anywhere, and actually the data is not in real life terms, it's not in Finland because Russia is close, it's actually in portals all over the world, so it's really truly very safe. This was a good solution because actually what happened that the risks of centralized storage realized last year. Neuromedia went to bankruptcy. Had we storage data with them, we had been in true problems, but now it's safe. We did not use OMOP or SNOMED to code the data. In 5 years ago, that was like and even though we had the best IT experts, they did not recommend it those days. We were able to harmonize the data across data from 2 countries, and so far it has not been necessary, but now being here, I'm happy to listen to your guidance that what kind of catalog should we apply, because we are of course applying for next EU Horizon project. As many of you probably know, there's now a call opened, and 16th April is the deadline to continue these studies. So the AI-based biomarker discovery, our partner NEC, which is a global technology company, has performed the AI-driven analytics in HUS Academic. Unfortunately, in our data, a biomarker seems not feasible. There are several disparate biological signatures, and our challenge now is to interpret whether they are signals of the mechanism or rather consequences of the lifestyle changes of long COVID. So we really have a very vast material here. We have like 1,000 patients, and we have not all of them, but we have blood, we have stool, we have studied the stool microbiome, then we have oral rinse to study periodontitis, and actually they have more that than the controls. And then we even have a spinal fluid from a subgroup of patients, but nothing worrying there in the spinal fluid as a comforting news for our patient participant here. So this is the situation now, and we would really like to continue to follow up these patients, because we would like to understand whether these quite weak biological signatures, whether they predict some long-term consequences like chronic fatigue syndrome, etc. Now the good thing about this academic is that it can now very well be linked to Finnish registers. And as you may know, we have quite good and wide registers in Finland for all sorts of things: primary healthcare data, secondary healthcare data, reimbursement, mortality, infectious diseases. But it's not straightforward, because 5 years ago when we launched this study, we were not able to write the consents so that all this linking would be possible. So at the moment we're actually asking new consents for better data sharing, because everything happens on the consent of the patient. So we had to renew the consents and run, but luckily also getting consents is easier now. 5 years ago, it was still on paper, but now HUS has a wonderful electronic system, and I can follow every day how many new consents we have got, and it's really fantastic. Things are moving forward. So we are aware of the fair implementation, and this safe environment ensures full compliance with data protection and governance requirements. We will make the metadata, perhaps when we have catalogued it, publicly available, and it is accessible to external researchers through a formal application and approval process. So no data can be downloaded, but access can be granted within the secure environment. Thank you. So please contact me if you have advice now in this challenging situation of submitting the proposal after 3 weeks. Thank you.
Let's close the panel with Stefan Schrek, an advisor of the EU Commission DG Santé. And Stefan will update us on the initiatives of the Commission to create links between the most advanced initiatives in Europe and to promote best practice.
So well, first of all, I have to say thank you for inviting me. And I think the presentations we have heard already provided a very good snapshot of all the research that is going on, and also which is really necessary. So let me tell that I would like to wish good luck to Helena for the new project under Horizon Europe. Yeah, I will focus today on long COVID more as a cross-cutting public health and societal challenge, and explain what we are doing in DG Santé and how the network of expertise on long COVID, the NELC, is helping to shape a more coherent European response. I will also briefly link this to the themes of this workshop on primary and secondary use of health data in the EHDS, without going too far into technical aspects. So long COVID, as we actually have heard, is not simply a prolonged recovery from COVID-19. Symptoms can be multisystemic, can fluctuate, and can last actually for quite a long time. People may struggle to work, to care for family members, or to participate in education and social life. The consequences are felt in primary and specialist care, rehabilitation, social protection, schools and workplaces. It's therefore a cross-cutting public health and societal issue that puts our system under real pressure and reveals how prepared we are for new, poorly understood conditions. Next slide, please. Yes. Why a European response? I should actually mention, and that's very important to understand, is that the European Union can only act if there is a legal basis in the treaty for the specific action it wants to take. And in the area of public health, it is clear that full responsibility is with member states. They organize their health system, they protect their citizens, and they also decide about the allocation of resources. And what we have to do whenever we want to do something in the area of health, we have to define what the European added value, as we call it, is. And that's a question, for example, which can be answered by something which cannot be done by member states on their own, or which can be done significantly better if it is done at EU level. And in case of long COVID, what we can say is that these challenges are not unique to any one country. All member states are grappling with similar questions: how to recognize long COVID, how to organize services, how to support people who cannot return to previous activity levels. If each country works in isolation, we are risking duplication, gaps, and very unequal support for patients. A European response allows us to share experience, learn from each other's successes and failures, and where appropriate, align approaches so that patients benefit from a higher, more consistent level of care and support across Europe. But I repeat, it's the member states which are responsible for allocation of resources and organization of the health systems, so we can just offer them an opportunity for learning from the others. The next slide, please. Yes, thank you. So this is the context in which the Commission, specifically my DG Santé, created the Network of Expertise on Long COVID, short NELC, in 2023. NELC brings together national centers of expertise and other key actors from EU and EEA countries. Its main purpose is to support member states and the Commission in developing a coherent, evidence-informed response to long COVID. And it does this by creating a structured forum where clinicians, public health authorities, researchers can regularly exchange experiences and lessons learned. The next slide, please. NELC's objectives are both practical and strategic. It works to build a more coherent, evidence-informed EU response by collecting national experiences, identifying promising practices, and highlighting common gaps and challenges. It also advises the Commission on where guidance, coordination, or funding can add value. The work spans several key areas: improving recognition and diagnosis, supporting clinical guidelines and care pathways, strengthening access to multidisciplinary care and rehabilitation, enhancing surveillance and research, addressing social and economic impacts, such as work and education, and ensuring that patients are meaningfully involved in shaping policies and services. Next slide, please. NELC is not just a theoretical discussion group, it is very practice-oriented. Members regularly present concrete national examples, how long COVID clinics are organized, for example, how primary care is supported, how rehabilitation services are structured and paid for, how social benefits and school or workplace arrangements are adapted. By comparing these approaches, the network can identify what works well, what could be scaled up, and where EU-level guidance or funding would be useful. NELC feeds this into EU initiatives such as the EU for Health Action that we have together with OECD and WHO, and also into planned research calls, one of which is open on post-infectious long-term conditions. In turn, it helps bringing the output of these initiatives, evidence, tools, training, and materials back to member states, basically helping them to use the results. Next slide, please. Yes, this is also a novel approach. An important strength of NELC is that it does not look at long COVID solely through a clinical lens. It also examines the wider social and economic impacts. How do we support people who cannot return to full-time work? How do schools accommodate children and adolescents with long COVID? How are social insurance and benefits adapted? The network gathers evidence and examples from different countries on these questions with the aim of shaping responses that are not only clinically sound, but also socially fair and comprehensive. This broader perspective is crucial if you want to reduce inequalities and avoid leaving the most vulnerable groups behind. And the last slide, please. Yes. Many of you in this room can actually contribute to NELC's work directly or indirectly. I would assume you can share national experience through your ministries of health, because NELC consists of members who have been appointed by the ministries of health. You can participate in the Commission's health policy platform, and those who are interested in that can just Google EU Health Policy Platform, and then you will find our platform and register for participating. There's also the open stakeholder group on long COVID, which, unlike NELC, is actually open to everybody who is a representative of an organization, our open stakeholder group, and that is part of the health policy platform. So if you Google that, you will also find our open stakeholder group. It ensures that patient voices and frontline perspectives are also heard. And you can help connect innovative projects and pilots, including those discussed in this workshop, with NELC and other EU-level processes, so that they can inform policy and practice rather than remaining isolated success stories. Long COVID's novel character and scale demand exactly this kind of structured collaboration. NELC is one of the key tools we have to turn scattered experience into shared learning, and shared learning into more coherent action across Europe. So that was it for today. Thank you very much.
Thank you, Stefan, for explaining what the EU is about to do and is doing about the long COVID. This is promising for the future, that we will have the support and a connection for all the different projects, and also some kind of equitable responses from all the countries, because we need to consider, of course, that each country is responsible for the provision of healthcare and might have several different organizations involved that might act also on different knowledge level and expertise. So we hope that the European action will soon try to understand what might be the best support for all of us, for all the country. Thank you, Stefan. So I will call the panelists to join us here. In this panel, we had the point of view of the different actors, starting from the initial description, where, of course, in the long COVID, just like in many other diseases, in all the other diseases, essentially, we have the role that are not so defined, because, of course, physician and patients and the institution organization works all together for the common goods, for the solution of this kind of problems. So do you have some question coming from the audience, coming also from the people connected remotely?
Yeah, it was more a question just after the presentation of Stefan, because we heard different presentations. Basically, well, we still see that all the projects are producing very important resources. We heard about the metadata that are being used in each of those projects. We heard about initiative like in the Netherlands, where they have been quite far already in trying to standardize everything which they believe could be standardized at some level. But is there already a process at the DG Santé level, both to use the existing codes to be federated and to collect all those experiences and translate that into some kind of active dissemination? Because I have the feeling that people still feel quite isolated. Although this network is existing, is it reaching the right people? That's my question. For you, Stefan, the question.
You want me to reply? Yes, indeed. That is absolutely the risk we have seen already since decades, I have to say. And the colleagues in DG RTD, so the ones which are managing Horizon Europe, run a specific process which is called feedback to policy, which gives an opportunity to projects to actually shape the development of policy with their evidence-based. That is one thing that exists, but that is, of course, a more general level. And I'm not sure what it actually contributes to federating projects. Which also happens. There's, for example, the cohort coordination board, specifically on COVID-related projects, which is something which is not run by DG Santé, but it's an initiative of DG RTD together with the coordinators of the projects in this area. And what we are doing, let's say, goes even a step farther than that. We are actually, we start from the point that the member states and the ministries of health are responsible for shaping their health policy. which essentially means if we at European level produce or collect or present results that can or cannot be used by member states, that is maybe not the ideal process. We are actually starting with asking the member states what they need in this area, because if they have no need, if they don't feel a need to apply a certain result, then it is rather unlikely that given the pressure under which health systems are under at the current time, this will actually be applied. So we started with asking the member states what they need. And that was a very productive process. And in our project, together with OECD and WHO, we actually concentrated exclusively on those things which member states considered particularly relevant. To give you just one point of that is a better case definition. As we heard already that by now more than 200 different symptoms have been identified for long COVID, and many of them appear in clusters of symptoms. And therefore, it is very difficult to have a good case definition. And if you don't have a good case definition, setting up research projects is very difficult, because in particular to federate them, because the different cohorts will have different recruiting criteria, which then makes the results not comparable. And so we are actually working on a better case definition together with the member states. This was not very successful so far, which is not really surprising because it's very difficult. And we have also heard today that having a good biomarker, which would be the ideal solution, is also not so easy. So that, but member states clearly identified a good case definition as a key requirement, both for actually research, but also for surveillance. Yes, maybe I stop here. I could talk a lot actually about what we try to collect results and make them available to member states.
We have a question from the audience.
Yes, thank you. Nienke Schutter from Cienzano, Belgium. I think it's interesting what you're touching upon here, Stefan. Thank you for your presentation. So you're talking needs of member states, so very member state level. But what is nice that we also had a presentation from a very bottom-up initiative. So I would perhaps like to invite Robert to comment on this. Do these needs on member state level are the same as at the level that you were presenting, more at the GP level, case definition, biomarker needs? Could you comment on this? Thank you.
This grassroots initiative that came up when the COVID epidemic raged had very little support from the member state level to continue the activity. It's basically a voluntary thing by one senior GP, and the biomarker research is fueled by the sampling in this cohort, and then very expensive research for proteomics and transcriptomics, which I see in Finland. There's a results for finding a biomarker doesn't have led to result. Well, this is, I'm not very well placed to put this very expertise research, but from what I heard is that the clustering of symptoms and the transcriptomics correlate. And that's, I think, a really important finding. The definition will be very difficult because it's multisystemic. And I think it will be important to be able to distinguish these clusters of symptoms, possibly corroborated by biomarkers. And that's a perspective that is, I think, real.
Thank you, Robert. We have a question from Kari, right? Just curious, when hopefully all this research machinery and organizational efforts are no longer needed for COVID in particular, what parts of it can be feasibly recycled for other public health purposes? This is perhaps something that might affect Schrek, but in the experience of Bianca as well, because how to revert or convert a network that is highly focused on just one disease to do something different?
I can start if you want.
Yes, please.
Yes. As I said, we have a long experience now that it is not self-evident that research results are actually taken up by all those who could benefit from them. And so we are doing more things to foster better collaboration between those creating new knowledge and those using it. Also, and in particular, again, with the ministries of health of member states. We have, for example, for the Europe's Beating Cancer Plan and the cancer mission, the cancer plan is done by DG Santé and the cancer mission is done by DG RTD, but we have only one group with member states overseeing the implementation of both plans. And from each member state, we have one representative from the Ministry of Health and one representative from the Ministry of Research, so that the representatives of the Ministries of Research can also see what the actual situation of the Ministries of Health are and vice versa. And we hope we foster better structured collaboration. And this, as Kari was asking, can this be recycled for other public health purposes? And in principle, it can be recycled for other health purposes, because usually if it's an important health purpose, there's both the public health angle and the research angle. We have this, for example, for rare diseases, and we also have it for cardiovascular diseases. And this is a long-term goal, because one has to see that in the end, the different departments, both at member state and at EU level, work still mainly in a very siloed way and don't look across the border to the other departments. So there is something to be improved in the future.
Yes, first Bianca, and then yes, please, Bianca, then Helena, and then Carmen.
Okay, thank you very much. Well, in the Netherlands, the PCNN is mainly an infrastructure that we're building, and we highly intend to broaden the scope to PICE in general, so to ME/CVS, Lyme, post-Lyme, post-sepsis, etc. And I don't think that will be a short-term thing to be solved in the near future. So, and also we try to build our tools open source so that it can be reused perhaps in other fields of research. So I don't think it will dry up when we solve the post-COVID problem. Let's hope we do.
Okay, thank you. Helena?
So similarly in Finland, we also think that some of these findings are relevant to other post-infectious conditions, and we have learned a lot during these 4 years. It has been a huge learning opportunity, like about the use of secondary healthcare data, for instance. But I mean, we now understand much better the qualities of the coronavirus. It's not a virus who remains in the body like herpes viruses, but there are other viruses that cause really severe post-infectious conditions like the EBV, which causes multiple sclerosis. So understanding better what different viruses can cause and use these tools and structures that we have now created creates a lot of new opportunities. But at the same time, I have started to think that it's not about the data only. It's about best research questions. I mean, we have to formulate good questions. And for me as a clinician, I think the most important questions are that how can we help these patients? What are the most effective interventions? So, I mean, with cohorts and secondary healthcare data, we may not necessarily be able to answer those questions. So still research is needed, especially on studying effective interventions.
Yes, thank you. I just wanted to mention that long COVID is not over. We hear from the specialists that they have new patients every week in their cabinets. So with every reinfection, the chance of getting long COVID is still high. And also, as mentioned by the other presenters, long COVID is not new. it's a post-infectious disease, and they should have been studied a lot more in the past. It wasn't done. So we hope that now with the long COVID and the large numbers of patients, the patients who are ill for many, many, many years and still become ill with other viruses, that they get treatment now too, that the research doesn't stop with long COVID, but that it is seen in a broader picture for all post-acute infectious diseases. They live in terrible conditions. I have many friends lying in bed for dozens of years in a silent, dark room. So let's learn from this pandemic, not only the COVID pandemic, but also the long COVID pandemic.
We have a question from the audience.
Yeah, Malcolm Clark representing SEN. I was going to ask a question, but in fact your panel's moved on to my question. I don't know if any of them have seen similarities between things like ME, where the symptoms are extremely similar to long COVID. And it doesn't, because it's not as visible as long COVID, it doesn't seem to be receiving the same amount of research. And so therefore the results that are coming out of the work on long COVID must and should be extended to these other diseases which result from a viral infection like COVID and then result in years of these fluctuating symptoms for patients.
Yeah, indeed. Well, we should analyze also the social impact and there are a lot of aspects that might, of course, affect the several diseases that are currently, not so well treated or investigated. But please, Robert.
An interesting research question is whether long COVID is due to persistent viruses or not. I heard you say that it's not like HIV persistent in the body. We are not sure about that. It is a hypothesis that it is a persistent viral infection hidden in parts of the body and still responsible for the symptoms. So it's an interesting hypothesis.
We have studied that a lot, also in the stool. One hypothesis was that it's in the stool or in the gut intestinal system, but no, it's not there. And also, our virologists believe that it is not because of the continuing viral infection, it's other causes. But I think we have been able to rule out some of these hypotheses, and that's also important.
Just to mention that I know a lot of people in France and some friends in Wallonie that have access to antivirals, and they experience a lot more quality of life since taking them. So I don't know what the research will bring, but I know that the patients who take these antivirals become better, or some of them.
Another question from the audience.
Yeah, a little bit back on the topic was mentioned earlier that I think it's interesting that now the long COVID has now the momentum, I think, but you also have what was mentioned, Lyme and ME/CVS. And then is it possible to learn from that part that is existing for a long time now? Is there any communication with other projects, or is it maybe a little bit of forgotten area? And then long COVID now starting, and then it will, what Bianca said, it will be, the scope will be broader. But I thought maybe learn from previous initiatives, maybe in the, or were there not here? Were there not big initiatives on Lyme or ME/CVS? For example, for you, did you have contact with other patients who have Lyme or something like that? So you see your patient journey. I think other patients maybe had the same journey, but for other diseases, but
Yes,
before
we
you.
see-
And
we
was there
see
something learned from that?
We see the same patient stories. So my journey started from long COVID, but we have a lot of similarities with patients who talk about their Lyme infections and their life past that infection. I have now a diagnosis of ME/CFS caused by long COVID, but we have stories of people with ME/CFS who get worse after COVID. So there's a lot of overlap. And I believe that there were small amounts of studies on these patient groups. And the moment that I started with medication examined in those studies in the past, I started getting better. So yes, thank you for your question. We really should learn from the past and these other diseases, but also yeah, they need more research because the medication for these diseases don't cure yet. So it's only giving me and other patients more quality of life. But of course, with all the new studies, we hope there will be medication that cures all these diseases.
Thank you. Question, I guess, for Helena. I take that HUS did not deploy federated analysis. Oh, sorry, Bianca, please.
Thank you. Well, I wanted to mention that actually we're working together with the NMCB Biobank. So that's the biobank from Amsterdam University for ME/CFS, where post-COVID patients are actually a small part of the data that's being, and the samples that is being collected within that cohort study. So there's already contact, and we are expanding our contacts to other organizations regarding other PIs. So yes, indeed, we do need to learn from other PIs that are already being researched.
Thank you, Bianca. Can we take the FRAPS? So again, I take that HUS did not deploy federated analysis methods to avoid limitation for physically moving data between secure data processing environment. So this is something.
Yes, we have performed federated analysis across Netherlands and the Swiss and Finnish data in Finland. And I think the federated analyses are the way forward because we have to operate with these safe environments.
Thank you. Another question from the audience.
Hello, Annarezza from DataWizard Italy. I would like to go back one moment to the research side, also taking advantage of the presence of Stefan here, because I've been in e-health research project for 10 years now, more or less, and I've always seen a pattern in cross-project collaboration. There is a lot of incentivization about cross-project collaboration. Now it's even mentioned in the topic descriptions of the calls. But in the end, it's always left to the initiative or the individual projects. There is no direction. And most of the time, it is reduced to joint dissemination and events, while the core research collaboration is never there. The research team do not participate in these joint events other than, the big events, the big cluster events from time to time. And the project officer are really absent in this area. So we hear from them when we have periodic reviews, but we would really like to have them coming to us and say, okay, you're doing this, there is this other project doing these things, and we would like you to work together and find a solution to this problem. And we would like to prioritize this. We would really appreciate that our project officer come to us and tell us what are the priorities, what we should work together with, on what. And that would be really helpful to support, not only for long COVID, for all the research areas we work in.
I don't know if Stefan want to say something about that.
You want me to say something about that? Well, I totally agree with your analysis. It would certainly be very valuable if you do just what you have described. The problem is that for that, there is not enough capacity. You might have noticed that the Commission has asked for a number of new posts for the next multi-annual financial framework, but received already a letter from 9 member states saying that certainly the Commission should not have those new posts. So I'm not so sure if so much will change in this. I think it is quite clear that there's always a tension between the care that can be taken for the supervision of the implementation of projects and the idea of having a rather low percentage of administrative costs for the implementation of the budget, which is also a very high political priority. So the point that you make could be part of the political discussion of how high the costs, the percentage of costs for project management should actually be. That's how I would see it.
Thank you, Stefan. I think if we don't have other questions, time is up. So I would like to thank all the panelists for your terrific contribution. Now perhaps we have something more clear, at least from the standpoint of how to approach the long COVID solution for the next future. So thank you all.
Thank you, Stefano. Thank you, Stefano, for moderating the session. So this will close our workshop of today. I think that was a lot of insights. As I said at the beginning, we're going to work further on the whole this material to consolidate some messages, because I think that there are important messages to be conveyed to the right people, both at the Commission level, but also at the member states level, to try to have the wonderful work done by patients, by clinicians, by researchers, and to have that recognized and federated, so that the existing infrastructure are better used. We mentioned a few ones. There are others. For example, Elixir is one of the other initiatives which allows already to connect data set today in a meaningful way. We have a lot of tools which have been developed for many different clinical domains. So you developed a specific infrastructure. You could have used a node from Elixir, which is completely under the control of researchers. So it's also about that. That's exactly what you meant. I mean, let's use the money we have for meaningful use, rather than building new infrastructure, redoing the same legal studies over and over again for the things that we know already. There is an urgent need in order to indeed use what we have better and more efficiently. That's what this workshop is about, connecting primary and secondary use to create, in the end of the day, value. More value for us, for society, for everybody. So thank you again, everybody, and we will be in touch.